Hello, my name is Jess Benson, and I'm a senior analyst with the Legislative Services Agency, and I have been staffing the Medicaid program for the last 15 years. Medicaid, or medical assistance, is a joint state and federal program created in 1965 under Title 19 of the Social Security Act, and it is the state health insurance program for low-income and disabled individuals. Medicaid is an entitlement program, which means that anyone who meets eligibility criteria must be served. States can't have wait lists for the program, and there is no limit on the federal match for eligible expenditures. Medicaid services must be available statewide to all members, meaning if Medicaid offers a service, it must be available for everyone to access. The service can't be available to just people in certain parts of the state. And while there may be a limited number of providers in some areas or fields of practice, any Medicaid member has the opportunity to be seen. Medicaid is managed on the federal level by the Center for Medicare and Medicaid Services, often referred to as CMS, which is part of the U.S. Department of Health and Human Services. CMS and the federal government provide the framework for the program, while states are responsible for administering it. In Iowa, Medicaid is administered by the Iowa Medicaid Enterprise, also referred to as IME, which is part of the Iowa Department of Human Services. When you think of Iowa Medicaid Enterprise, think of a large health insurer such as Wellmark here in Iowa. The Iowa Medicaid Enterprise has a limited number of state employees, approximately 60, and runs most of their operations by third-party contracts. A common confusion among people not familiar with Medicaid is to confuse it with Medicare, and this graphic details some of the key differences. Medicare is administered by the federal government, and the state doesn't play any role in the program, whereas Medicaid is administered by the state with federal oversight of the program. Medicare is funded solely by the federal government, and Medicaid is funded by a combination of state and federal dollars. Medicare covers individuals age 65 and older and people with certain disabilities. Medicaid covers low-income adults, pregnant women, children, some disabled, and some elderly. Medicare coverage is consistent across all 50 states, and they are a primary healthcare payer. So if you're in Arizona, Florida, or California, you're going to have the same benefits package no matter where you're at. Medicaid coverage varies across all 50 states because states have been given the flexibility to administer the program. So the Medicaid program is different in South Dakota, Iowa, Nebraska, or Minnesota. Medicaid is also the payer of last resort. For example, a low-income elderly individual may be covered by both Medicare and Medicaid. Medicare would be the primary insurer, covering things like doctors and hospitals, and Medicaid would be the payer of last resort and would cover prescription drugs, Medicare Part D, and long-term care, such as nursing home. As mentioned on the previous slide, Medicaid is financed jointly by the state and federal government, and the formula used to determine how much the state pays is called the FMAP Formula, or the Federal Medical Assistance Percentage. The formula is based on a 3-year rolling average of per capita income for each state as calculated by the Bureau of Economic Analysis. Per capita personal income is used in the formula because it represents a state's ability to tax its base and therefore fund the Medicaid program. FMAP rates vary widely from state to state, ranging in FY23 from a high of the federal government paying 77.86% in Mississippi to the floor of 50% in a number of wealthier states and states with significant natural resources, such as Alaska and Wyoming. If the formula did not have a floor, Connecticut, the wealthiest state per capita, would receive a federal match rate of 18.49%. Iowa's FMAP rate of 63.13% ranks in the middle of all states in the District of Columbia. Iowa's FMAP rate has fluctuated between a low of 51.96% in FY 1979 to a high of 65.04% in 1992. Before the farm crisis of the 1980s, Iowa's FMAP rate was nearing the federal minimum of 50%. With the beginning of the farm crisis, the FMAP rate began a steady climb to approximately 63%, where it remained until 2011. During the most recent recession, which began at the end of 2007, Iowa's economy fared much better than those of other states, in large part due to a strong farm economy. Due to the stronger economy conditions compared to most states, the Iowa FMAP rate began a steady decline beginning in FY 2011, declining 8.6% between FY 2011 and FY 2016. Beginning in FY 2017, the FMAP rate began trending back up to make up most of the difference from the shift in the previous 6 years. Each percentage change of the FMAP rate equals approximately $40 million shift from the federal government to the state or vice versa. Moving on to eligibility. To be eligible for the Medicaid program, you must be categorically eligible unless you are participating in the Iowa Health and Wellness Program. This means you must fall into a specific category such as child, pregnant woman, elderly, or disabled. In addition to being categorically eligible, you must also provide documentation proving you are a citizen and provide identification. Medicaid is only available to U.S. citizens with the exception of some emergency cases where it's paid for 100% by the federal government. In addition to being categorically eligible, you have to meet income requirements and have income at or below a certain poverty level. Income requirements vary by category, with children and pregnant women being covered up to 300% of the federal poverty level. This includes children from 1 to 18 who are covered by the Hawkeye program. Incomes for other categories vary, but most are at or below 100% of the federal poverty level. The typical family on Medicaid is a single mother with 2 children. For her family, 100% of the federal poverty level is just over $23,000 a year. This chart shows the federal poverty level by family size for calendar year 2022. The left side shows family size from 1 to 8, and the top shows incomes from 25% to 300% of the federal poverty level. This slide shows enrollment in the regular Medicaid program. As of December 2021, there were 495,184 individuals enrolled in Medicaid. As you can see, the majority of the individuals enrolled are children. This slide shows Medicaid actual 2-year enrollment. Before COVID-19, Medicaid enrollment was relatively flat, with enrollment between 420 and 430,000 individuals per month. Since March of 2020 and the onset of the COVID-19 pandemic, the Medicaid program has seen a large spike in enrollment due to the federal requirement prohibiting states from disenrolling anyone while the federal public health emergency is in effect. The state is receiving an enhanced 6.2% FMAP rate to fund the additional growth. The 6.2% enhanced FMAP is currently set to run through March of 2022, but will likely be extended through at least June of 2022. This graphic is to give you an idea of the size of Iowa's Medicaid program in relation to other insurers in the state. The program covers 1 in 2 births, 1 in 2 children, 1 in 5 adults, 1 in 10 elderly, 1 in 4 individuals with disabilities, and 1 in 2 residents of nursing homes. The program includes the Hawkeye program and the Iowa Health and Wellness program, as well as the Medicaid program. Looking at the total number of individuals covered, Medicaid is the second largest insurer in the state, behind Wellmark. Prior to April 1, 2016, Iowa Medicaid's health coverage operated mainly under a fee-for-service model. In a fee-for-service model, providers are paid for each service they provide, such as an office visit, blood test, or surgery. Iowa Medicaid Enterprises previously handled over 23 million claims per year and contracted with over 38,000 providers. Beginning April 1, 2016, coverage of 94% of Medicaid members was transferred to management of 2 managed care organizations. Although the state is currently in the process of procuring up to 2 additional managed care organizations. MCOs are companies that have the goal of managing costs and utilization and improving quality. MCOs may have a fee-for-service payment relationship with providers, or they may have a value-based contract relationship. Managed care organizations work by contracting with the state and accepting a set per member per month capitation payment for services. So for everyone enrolled with an MCO in any given month, the MCO will receive a payment based on the expected cost of their care. For example, an MCO would receive $149 per month for a healthy child, and the MCO would receive $3,356 per month for a grandmother in a nursing home, regardless of how much care either of them may use. The MCO will spend more on some individuals and less on others, but on average, across all 700,000 plus members enrolled on Medicaid, Hawkeye, and the Iowa Health and Wellness Program, the MCO will likely break even with a small profit. When Title 19 of the Social Security Act was passed back in 1965, the government laid out a certain set of mandatory services, including most of the big ones you would expect, such as doctors, hospitals, and nursing home care. States are required to provide these services to receive federal Medicaid match. The federal government also allows a list of optional services, giving states the opportunity to customize their program. Here is a list of the main optional services available under the program. The list is not all-inclusive. Healthcare coverage has changed significantly since 1965, and some of these optional services, like pharmacy, are no longer really optional in the way healthcare is provided today. But the legislature does have the flexibility to make changes to these optional services, including changing the amount, scope, or duration of some of these services that are provided. One optional service that you will likely hear a lot about are the home and community-based services waivers. The HCBS waivers were established back in 1981, and they get their name because states are getting a waiver from certain requirements in federal law, such as providing all services to all members, or income requirements, so they can target certain populations who are at greater risk of being institutionalized. Iowa has 7 different home and community-based services waivers that you can see on the screen, and the goal of those waivers is to keep individuals out of institutions and in the communities. Here's a list of some of the more common services provided to individuals on the HCBS waivers. They are things like adult daycare, consumer-directed attendant care, which helps people with activities of daily living, such as bathing, brushing teeth, laundry, or getting groceries. There are personal emergency response devices. Transportation is provided to get people to things like medical appointments or jobs. Home and vehicle modification is available to make things wheelchair accessible or safer to prevent falls. Respite is a significant service for parents taking care of children with disabilities, allowing the parents to get out of the house for a break. A lot of these services are smaller wraparound services, but they make a big difference in allowing individuals to remain in their homes or in the community. Changing gears, as part of the Affordable Care Act, or Obamacare, Iowa was able to expand their Medicaid program to cover all adults from age 19 to 64 with income between 0 and 133% of the federal poverty level, and who don't have any other insurance options. The program is called the Iowa Health and Wellness Program. Members who are enrolled in the program have access to the same provider network as the regular Medicaid program and have a coverage benefit equivalent to the state employees' health benefits package. Enrollees are eligible for 12 months with income re-verified for eligibility near the end of the 12-month period. Unlike the Medicaid program, the Iowa Health and Wellness Program does require some financial contributions in certain circumstances. There are no co-payments except for an $8 copay for using the emergency room when it's not a medical emergency. There are no monthly contributions or premiums in the first year, and no contributions after the first year if a member completes a health risk assessment and has a health wellness exam or a dental wellness exam. Monthly contributions are only for individuals with incomes at 50% of the federal poverty level or above, if preventative services or wellness activities were not completed in the previous year. If a member fails to complete the specified activities, a premium of $5 per month will be charged to an individual with income between 50 and 100% of the federal poverty level, and a premium of $10 per month will be charged to an individual with incomes between 101 and 133% of the federal poverty level. Total out-of-pocket costs, including both premiums and co-payments, cannot exceed 5% of an individual's income. As of December 2021, there were 242,109 individuals enrolled in the Iowa Health and Wellness Program. The program has seen the same surge in enrollment due to the 6.2% FMAP maintenance of effort requirement, which prohibits anyone being disenrolled from the program during the public health emergency. Since March of 2020, the program has added 59,816 individuals. I should note that once the pandemic ends, the Department of Human Services will reassess eligibility for everyone on the program, and although it's difficult to estimate because we have never experienced anything like this before, we're estimating that somewhere between 70 and 85% of the increases seen during the pandemic will no longer be eligible and will be disenrolled from the program. Moving on to program expenditures. Total expenditures for both Medicaid and the Health and Wellness Program totaled $6.125 billion for fiscal year 2021. The top 6 expenditure categories were hospitals, nursing facilities, intermediate care facilities, the home and community-based services waivers, mental health, and physician services. No surprise, the most expensive things are hospitals and long-term care. The match rate does not exactly equal the 63% regular Medicaid match rate because the Health and Wellness Program receives a 90% federal match rate, and there are various other match rates under the program. This slide illustrates how expensive long-term care is. While children and adults make up roughly 75% of Medicaid enrollment, they only account for about a third of Medicaid costs. And it's the opposite for the other two. The elderly and disabled make up roughly 25% of enrollment, but account for 2/3 of Medicaid costs. Providing health care for children is relatively cheap, but paying for hospitals and long-term care and doctors for the disabled and elderly is not. What drives costs? The most obvious thing is enrollment. The more people on the program, the more the capitation payments will be to the MCOs, and the greater the cost. The next thing that drives cost is the utilization of services. Medicaid works just like any other insurance company. If doctors are ordering more MRIs, or if there is a hot new treatment, costs are going to increase. Changes in federal law also help drive cost. The change in the FMAP rate can change state Medicaid expenditures by millions of dollars one way or the other, depending on which direction it moves. Also, there are things like Medicare Part D payments. Medicaid pays the federal government for Medicare Part D for people on both Medicare and Medicaid. The payment generally increases $7 to $10 million a year, but it's going up $19.3 million for fiscal year 22 to 23, mainly because of the new Alzheimer's drug that was recently approved by the FDA. Changes in state law also helps drive costs. If you're a lawmaker and add new services or coverage groups or increase provider rates, that increase could change Medicaid costs. So what are legislators' responsibilities when it comes to Medicaid? Well, the first thing is setting rates. Every year, Medicaid provider rates are set in the Health and Human Services appropriations bills. So if legislators want to give provider rate increases, they can do so. There's a rate section in the bill which details provider rates for every provider. Generally, if the legislator wants to increase provider rates, they would put a percentage increase or a dollar increase next to the provider in the rate section. The second thing that legislators are responsible for are deciding the amount, scope, and duration of optional services. For example, if a legislator thinks a new service needs to be added, they can direct the IME to do so. They can also direct them to provide more or less of certain services. Legislators are also responsible for setting rules, regulations, and processes not governed by the federal government, such as prior authorization for services or additional provider audits. For example, legislators could require that hospitals need to have a prior authorization before ordering an MRI. Legislators are also responsible for changing eligibility, premiums, or enrollment fees, or imposing more restrictive eligibility procedures except when prohibited by federal law. The LSA, the DHS, and the Department of Management staff members meet regularly to discuss estimated Medicaid expenditures and agree on an estimated need or surplus for the current and upcoming fiscal years. At the December 23, 2021 meeting, the group agreed that Medicaid will have a surplus of $257.9 million for fiscal year 2022 and $160.8 million in fiscal year 2023. This estimate assumes that the 6.2% enhanced FMAP rate will expire at the end of March. If that enhanced FMAP rate runs through the end of June, this estimate could be increased by $30 to $40 million in each fiscal year. This page has a list of helpful publications that I have recently written related to Medicaid and the Iowa Health and Wellness Program, and has my contact information listed at the bottom of the page. If you have any questions regarding this presentation, please feel free to email me or call me at the number listed below. Thanks for your interest in Iowa Medicaid.